Good afternoon, our dear students. Today we continue lectures for third year students for discipline of Propaedeutics of Internal Medicine. And today you have a first day of your second semester this year. This lecture from MA groups who have a second semester just now. And according to our schedule, or according to our thematic plans, we continue the cycle of lectures in these disciplines. And you remember that previous semester we have several general lectures, and after it was a cycle of lectures in cardiovascular system, the general diagnostics of cardiovascular system, and several lectures by syndrome. It was arterial hypertension, heart failure, chronic and acute coronary disease, heart failure. And previous semester we started a new system. It is a respiratory system, and we have two lectures for respiratory system disorders. And today we continue this system. We continue signs and symptoms of respiratory system diseases. And topic of our today's lecture is syndromes from fluid accumulation in pleural cavity to respiratory failure. It will be a range of several syndromes. And before we start in a material, I remind you that during lecture you will have some questions, all of them during lecture for your individual self-work, just for your interesting. If you are attentively listen lecture, maybe it will be interesting for you to answer on some questions. All lectures this semester will be on my YouTube channel. You should subscribe it, and according to time in your schedule, we will have lectures for this discipline. And as usually, for checking the attendance, I ask students to write a name and group number under the video in YouTube comments. Okay, let's start the lecture. Like a preamble, I want to remind you the importance of the respiratory system. You saw this slide in previous lecture, it just reminding. Since our childhood, we are all aware that food, water and oxygen are basic necessities of life, and we can't survive without them. The average person can live without food for 3-4 weeks. We cannot survive without water for more than 3-5 days. Oxygen is crucial to sustain life, and 3 minutes is the maximum time where the person can stay alive without breathing. And for the start, I want to give you a USMLE test for your individual work. Who can answer? You should know it to your conspect. The answer, if you don't know, please fix this question for yourself, and I hope that after the lecture you will answer easily. A question. A 78-year-old woman with a past medical history of heavy alcohol and tobacco use, esophageal cancer and chronic pancreatitis present to the emergency room with shortness of breath. Her blood pressure is 165/94, heart rate is 118 beats per minute, respiratory rate is 31 beats per minute, and saturation of oxygen is 78% on room air. She then undergoes a thoracocentesis for evaluation for the left-sided pleural effusion. Which of the following results is consistent with a pleural effusion secondary to an esophageal perforation? And options for this question. First, it is fluid LDLH or lactate dehydrogenase when serum LDH ratio of 0.5 to 1. Second option, fluid LDH of 15 international units per liter. In normal, it have to be less than 300. Third option, fluid protein. Relation between fluid protein and serum protein ratio is 0.6 to 1.4. Fourth option, a fluid protein of 10 grams per liter, normal less than 25. And fifth option, a gram steam is needed to order the evaluate this question. Plan of our today's lecture. What are we working for? First, syndromes. It is dry and exudative pleuritis. Next, it is pleural effusion. It connected with exudative pleuritis, and it is a logical result of it. Next one, it is a lung compression syndrome. After, I'm going to speak a little about obstructive sleep apnea, which is very often and very important disorder. Next syndrome for today, it is acute respiratory distress syndrome and respiratory failure. We have a lot of work. Let's start. A dry and exudative pleuritis, and let's give a definition to these syndromes. Pleuritis or pleurisy, it is inflammation of the pleura that surrounds the lungs and line the chest cavity, and can result in a sharp chest pain with breathing shortness of breath, cough, fever, or weight loss, depending on the underlying cause. Ordinary distinguish the dry form, we name it dry pleurisy, or wet form or exudative pleurisy of pleuritis. The wet form of pleuritis is accompanied by a pleural effusion. The dry of pleuritis often precedes exudative of pleuritis or pleural effusion. Most patients suffer from exudative pleuritis, and dry pleuritis, they are much more rare. What about causes? The most often cause is a viral infection, not bacterial. You remember that pneumonia, it is a mostly bacterial disorder. It can be viral, but more rare than bacterial. For pleuritis, it is the opposite relation. Mostly it caused by viral infection. Other causes include pneumonia, including bacterial, pulmonary embolism, autoimmune disorders, lung cancer following heart surgery, pancreatitis, chest trauma, and asbestosis. It is the most often possible causes of pleuritis. Occasionally, the cause of pleuritis remains unknown. We can't find any significant cause. The defining symptom of pleuritis is sudden, sharp, stumbling, burning, or dull pain in the right or left side of the chest during breathing, especially when one inhales and exhales. Pain feels worse with a deep breathing, coughing, sneezing, or laughing. The pain may stay in one place, or it may spread to the shoulder or back. Sometimes pain becomes a fairly constant dull ache. Depending on its cause, pleuritic chest pain may be accompanied by other symptoms like dry cough, fever and chills, rapid shallow breathing, shortness of breath, tachycardia, sore throat, followed by pain and swelling in the joints. History taking into account of patient's symptom we usually need for diagnosis. Auscultation and percussion of the lungs. When dry pleuritis, physician may hear noises, pleural friction characteristics. On chest X-ray, it is a pleural effusion. Laboratory findings, it is inflammatory parameters like mostly we can find white blood cells, blood sedimentation rate, C-reactive protein that are generally increased during inflammation. Moreover, for diagnostics, we can identify the pathogen. In case of autoimmune disease, antibodies can be measured. A puncture of pleural effusion and microscopic and chemical analysis of liquid. Next syndrome, it is pleural effusion. I told you that it is connected with exudative pleuritis, and it is excess fluid that is accumulates in the pleural cavity. the fluid-filled space that surrounds the lungs. The fluid excess can impair breathing by limiting of expansion of the lungs more than 500 milliliters. Various kinds of pleural effusion depending on nature of the fluid and that caused its entry into the pleural space, and we name it by the term hydrothorax or presence of spheroid fluid in pleural cavity. It can be hemothorax when it present blood in pleural cavity, urinothorax when it is urine in a pleural cavity, chylothorax when it is presence of chyle, or pyothorax when pus is placed in a pleural cavity. Causes of pleural effusion. It can be exudative and transudative. Exudative, it is about inflammation. Exudate, it is inflammatory fluid. Transudate, it is not inflammatory fluid. That's why all causes of fluid in a pleural cavity we can divide on these two types. It is transudative causes and exudative causes. Transudative causes include the most often cause, it is congestive heart failure. Moreover, it can be caused by liver cirrhosis, hypoproteinemia, nephrotic syndrome, acute atelectasis, myxedema, peritoneal dialysis, obstructive uropathy, and stage kidney disease. Exudative causes, what I told you, it is inflammatory causes. Yes, it can be pneumonia, it can be cancer, pulmonary embolism, kidney disease, and inflammatory disease. Other less common causes, it is tuberculosis, autoimmune disease, bleeding, mostly due to chest trauma, chylothorax, due to trauma too, rare chest and abdominal infections, asbestos pleural effusion due to exposure of asbestos. It can be Meigs syndrome due to benign ovarian tumor and due to ovarian hyperstimulation syndrome. Symptoms of pleural effusion. In clinic of such patients, often we can see any symptoms, no symptoms at all. Symptoms are more likely when a pleural effusion is moderate to large size or if inflammation is present. Symptoms of pleural effusion may include shortness of breath, chest pain, especially on breathing in deeply, like for example in pleurisy or pleuritic pain, and they can include fever and cough. For diagnostics of pleural effusion, it usually diagnosed on the basis of medical history and physical exam. Usually all that you need for diagnostics we can find during conversation and objective examination of patient. It is enough to suspect pleural effusion, and after it we should confirm it by chest X-ray studies. Above the effusion, where the lung is compressed, there may be bronchial breathing and egophony. A large effusion, they may cause tracheal deviation away from the effusion. Once accumulated fluid is more than 300 milliliters, there are usually detectable clinical signs in the patient, such as decreased movements of the chest on the affected side, stony dullness to percussion over the fluid, diminished breath sounds of the affected side, decreased vocal resonance and fremitus. Though this is an inconsistent and unreliable sign. And pleural friction rip. The most commonly used additional tests, what the most often, I told you that the most specific and informative here, it is chest X-ray. Additionally to it, when it is not enough chest X-ray, it can be used computer tomography scan of the chest. It can be ultrasound of the chest. It can be thoracocentesis, Pleural fluid analysis. It is an examination of the fluid removed from the pleural space. Thoracentesis. Pleural fluid is drawn out of the pleural space in a process called thoracentesis. How it looks you see on the picture. And it should be done in almost all patients who have pleural fluid that is more than 10 millimeter, more than 1 centimeter of thickness. In thoracentesis, a needle is inserted through the back to the chest wall in the 6, 7 or 8 intercostal space in the mid-axillary line into the pleural space. Usually, according to percussion, according to additional test visualization, we find a level of fluid and we choose what intercostal space 6, 7 or 8, and in this place on posterior axillary line we do injection and remove excess of fluid. Fluid that we take after thoracentesis, we should check, we should do some investigation of it. It's checked for red cell counts and they can be elevated in cases of bloody effusions, for example after heart surgery or hemothorax. Pleural fluid amylase is elevated in cases of esophageal rupture, pancreatic pleural effusion or cancer. Glucose is decreased with cancer, bacterial infections or rheumatoid pleuritis. Pleural fluid pH is low in empyema, it usually less than 7.2 and may be low in cancer. If cancer is suspected, the pleural fluid is sent for cytology. If cytology is negative, either a thoracoscopy or needle biopsy of pleura may be performed. The fluid is also sent for gram staining and culture, and if suspicious for tuberculosis, examination for TB markers. What markers? It is adenosine deaminase, more than 45 international units in liter, interferon gamma, more than 140 picograms per milliliter, or positive polymerase chain reaction for tuberculose DNA. Once pleural effusion identified as exudative, additional evaluation is needed to determine the cause of the excess fluid, and pleural fluid is sampled for amylase, glucose, pH, and cell counts. Criteria when fluid is exudative, what we discussed, or transudative. According to investigation of fluid, we can divide this type of fluid. By the main cause, transudate will be with high hydrostatic pressure and low colloid osmotic pressure. Exudate due to inflammation increase vascular permeability. By the appearance, transudate is usually clear, exudate is cloudy. By specific gravity, transudate is less than 1.012, exudate more than 1.02. By the protein content, for transudate it's typical less than 2.5 grams per deciliter, for exudate more than 2.9. By the fluid protein, a relation between fluid protein and serum protein, it's less than 0.5 for transudate and more for exudate. Difference in albumin content with the blood albumin. More than 1.2 grams per deciliter for transudate and less than this number in exudate. Fluid LDH upper limit for serum for transudate less than 0.6 or less than 2 from 3 and more than 0 less than 0, sorry, and for exudate more than 0.6 or 2 by 3. By cholesterol content, For transudate, it's typical less than 45, and for exudate, more than 45 milligrams per deciliter. And one more usable e-test for you by our today's topic. A 54-year-old female presents to the emergency department complaining the shortness of breath. She does not speak English and her medical history is unknown. Her temperature is 100.1 Fahrenheit in Celsius and 37.8. Blood pressure is 130 by 85 millimeters hydroradium, pulse is 105 per minute, and respiration 24 per minute. Physical examination reveals bilateral rales and dullness to percussion at the lung bases that is worse on the left. Hepatosplenomegaly is noted. Chest radiograph on the picture. I did not include picture, that's why we have just clinical picture, just objective symptoms. Electrocentesis and hematologic analysis are performed with the following result: pleural lactate dehydrogenase 54 units per liter, serum lactate dehydrogenase 82 units, proteins serum total 7.0 grams, proteins in pleural fluid 3.8 grams. Question: which of the following conditions is most strongly associated with these findings? First option, pulmonary embolism. Second, cirrhosis. Third, nephrotic syndrome. Fourth, protein losing enteropathy. Fifth, congestive heart failure. And next syndrome that I'm going to discuss with you today, it is lung compression syndrome, or another name of this syndrome is atelectasis. Let's give definition and discuss the types of it. Atelectasis is defined as a collapse of part or all of the lungs. When this occurs, for whatever reason, fresh air does not reach the thinnest airways, and oxygen and carbon dioxide can be exchanged. This in turn can lead to decreased levels of oxygen being delivered to the organ and tissues in the body. We name this situation hypoxia. Atelectasis may be acute, it occurring suddenly over a matter of minutes, or chronic, developing over a period of days to weeks. Atelectasis may be a result of a blocked airway, obstructive, or of pressure from outside the lung, or not, it is named non-obstructive. Almost everyone who has surgery has some atelectasis from anesthesia. Atelectasis is particularly prominent after heart bypass surgery. Mechanisms of it. First mechanism, it is obstruction. Obstruction, it is a blockage of an airway either from inside by foreign body that is aspirated, or by mucus plug. Or it can be obstruction from the outside, for example by the lung cancer that pressing on bronchi and obstruct them. Second mechanism, it is compression. Compression of the airways in the lungs can be caused by fluid or air surrounding the lungs, as in pleural effusion or pneumothorax, by enlargement or an aneurysm of heart, by tumors such as cancer metastatic to the lungs, lymphomas, and enlarged lymph nodes, or by abdominal distension which causes pressure on the lungs. Third mechanism, we name it adhesion. When a surfactant is lacking, I hope you remember from pathophysiology what is surfactant. When it is deficit of it, the lungs lose surface tension and can collapse. This is in the case of respiratory distress in newborns, and can also occur in adults with adult respiratory distress syndrome, or ARDS. It can be in smoke inhalation and kidney failure. Next mechanism, fourth one, it is hypoventilation. It is a failure to take deep breath can result in collapse of part of the lungs during surgery, especially with general anesthesia, and then breathing in the shallow due to pain, such as with rib fractures. Causes of it, let's discuss first of all obstructive causes. We're told that it can be foreign body or mucus plaque. For example, mucus plaque after accumulation of mucus in airways, often occurring during the and after surgery in children, people with cystic fibrosis, and during severe asthma attacks. Foreign body is common in children who have inhaled an object such as a peanut or small toy part in their lungs. Narrowing of the major airways from the disease, for example, like chronic infections, including fungal infections, tuberculosis, and other diseases. It can be tumor in the major airway. It can be blood clot after significant bleeding into the lungs that can't be coughed out. Non-obstructive causes. It is injury or chest trauma. It is pleural effusion, pneumonia, pneumothorax, scarring of lung tissue, and often it unfortunately tumor. Examples of it you see on X-ray pictures on this slide. Symptoms of atelectasis. Atelectasis may have few or no symptoms at all if it develops slowly or involves only a small portion of the lungs. Conversely, if the condition affects a large portion of lungs or develops rapidly, symptoms may be dramatic and may even progress to shock. Common symptoms include shortness of breath. It is the most common symptom. Coughing, over described as hacking, and is most often productive, meaning that no mucus is coughed up. Pleurisy, chest pain that is sharp and worsens with a deep breath or coughing. We name it pleuritic chest pain. And in inflammatory disorders, the often symptom is fever. At one time, it was thought that fever was a sign. Pleural examination. We use it for physical examination, we use it for diagnostics. Findings here may include quiet or absent breath sounds above the damaged part. In chest X-ray, the trachea and heart may be deviated toward the side of the chest where the lung is partially collapsed. The diaphragm may also be elevated on the side of the collapse. On the chest, CT scan may further define an area of possible atelectasis and to look for other causes of obstruction, such as tumors or enlarged lymph nodes. On bronchoscopy, that is often used for diagnostics, it can determine the cause of bronchial obstruction. Blood gases or oximetry may be done to determine how much atelectasis is interfering with the ability to get oxygen to your tissues. Other tests. They may be ordered depending upon the condition, for example, and blood work to evaluate kidney function. And here is the example of obstructive atelectasis due to inhaled peanut, and you see on bronchoscopy the piece of this peanut in a left main bronchus. One more test for you. A 37-year-old male is brought to the emergency department following a motor vehicle accident. On arrival, respirations are shallow. Blood pressure is 80 by 60 mm hydroargon, pulse 122, respiratory rate 29. Physical examination demonstrates absence of breath sounds on the patient's left side. Chest radiograph is shown on the figure. You see a picture of X-ray on the left upper. Which of the following is the most appropriate next step in management? First option, it is echocardiography. Second, needle thoracostomy on the left second intercostal space. Chest tube placement in the left fourth intercostal space. Fourth option, transfusion of packed red blood cells. And fifth one, it is endotracheal intubation. Next syndrome for today, it is obstructive sleep apnea. Let's give a definition. Obstructive sleep apnea is caused by obstruction of upper airway. It's characterized by repetitive pauses, or we name it apneas, in breathing during sleep, which typically last 20 to 40 seconds despite the effort to breathe. Obstructive sleep apnea is usually associated with a reduction in blood oxygen saturation. OSA is commonly accompanied with snoring. The main cause of OSA are old age, temporary or permanent brain injury, decreased muscle tone, excess soft tissue around the airway, common with obese patients, something physical in the throat or mouth jaw shape. Symptoms of obstructive sleep apnea include excessive daytime sleepiness. For this patient, feel acute deficit of sleeping. Often in most patients it is loud snoring. It is episodes of breathing cessation in sleep. It is abrupt awakening by the shortness of breath and awakening with a dry mouth and sore throat. Moreover, it can be awakened with a chest pain, morning headaches, difficulty concentrating during the day, experiencing mood changes, difficulty staying asleep, and high blood pressure. You see how a lot of symptoms, a lot of problems caused by this syndrome. For diagnostics of obstructive sleep apnea, we usually perform nocturnal polysomnography. It records brainwave changes, eye movements, leg movements, blood oxygen levels, muscle tone, heart rhythms, and respiration during sleep. Moreover, we usually do such patients oximetry and check them for Epworth sleepiness scale to measure the patient's level of daytime sleepiness. It can be 3 ratings of obstructive sleep apnea. Mild include 5-14 episodes of apnea or hypopnea per hour. Moderate from 15 to 30 episodes of apnea or hypopnea per hour, and severe over 30 episodes of apnea or hypopnea per hour. Nocturnal polysomnography. It result and interpretation looking like this on the picture. Here you see a 30-second approach of the polysomnographic recordings in the 13 channels that include muscular tension, eye movements, bioelectrical brain functions, heart rate, breathing with flow, some upper and lower effort, snoring, body position, and oxygen saturation. And all these parameters are drawn like a graphic, like a scheme on this result. During the first 10 seconds, an obstructive sleep apnea cessation of breathing is clearly visible as a flat line in a flow channel. And how it looks, Epworth sleepiness scale question. You remember it is for checking daytime sleepiness. Patient should graduate a lot of situations by the scale from the 0 that would never fall asleep. 1, it is slight chance to fall asleep. Second, moderate chance, and third, hard chance to fall asleep. And different situation: sitting, reading, watching TV, sitting inactive in public place as a passenger in car, and and another situations, and patient put a number of balls, number of points for each situation, what the chance to fall asleep. Okay, USMLE test, one more. A 63-year-old man presents to the physician complaining the excessive daytime sleepiness. This problem has worsened slowly over the past few years, but is now interfering with his ability to play with his grandchildren. He worked previously as an overnight train conductor, but he has been retired for the past 3 years. His wife notes that he often snores loudly during sleep. He has also been experiencing headaches in the morning and endorses a depressed mood. His physical exam is most notable for his large body habitus, BMI of 34. What is the best description of the underlying mechanism for this patient's excessive daytime sleepiness? First, it is insufficient sleep duration. Second, circadian rhythm sleep-wake disorder. Third, poor oropharyngeal tone. Fourth, deficiency of the neuropeptides orexin A and orexin B. And fifth, psychiatric disorder. And next syndrome, acute respiratory distress syndrome. Let's give definition and discuss the causes of it. Acute respiratory distress syndrome or respiratory distress syndrome or acute lung injury, adult respiratory distress syndrome or shock lung, it all synonyms. It is a severe, life-threatening medical condition characterized by widespread inflammation in the lungs. Common causes of acute respiratory distress syndrome include sepsis, pneumonia, trauma, multiple blood transfusions, babesiosis, lung contusion, aspiration of stomach contents, and drug abuse or overdose. Other causes of acute respiratory distress include burns, pancreatitis, near drawing, or the inhalation of chemical irritants such as smoke, phosgene, or chlorine gas. Some cases of ARDS or acute respiratory distress syndrome are linked to the large volumes of fluid used during post-trauma resuscitation. This syndrome has a high mortality between 20 and 50%. Mechanisms in acute respiratory distress syndrome is pathology of the microscopic air sacs in the lungs alveoli. You should learn it on pathophysiology. It leads to decreased exchange of oxygen and carbon dioxide, like gas exchange. Acute respiratory distress syndrome associated with several pathological changes and release of inflammatory chemicals, breakdown of the cells lining the lungs, blood vessels. Surfactant loss leading to increased surface tension in the lung, fluid accumulation in the lung, and excessive fibrous connective tissue formation. The signs and symptoms usually begin within 72 hours of the initial insult or injury to the lung and may include severe shortness of breath, fast breathing, cough, and low oxygen level in the blood. A chest X-ray frequently demonstrates generalized infiltrates or opacities in both lungs, which represent fluid accumulation in the lungs. Other signs and symptoms of acute respiratory distress may be associated with underlying disease process, like low blood pressure and fever. We have a Berlin criteria of 2012 proposed by European Society of Intensive Care Medicine, endorsed by American Thoracic Society and Society of Critical Care Medicine. They're usable for diagnostics of acute respiratory distress syndrome. These criteria include acute onset, bilateral infiltrates on chest radiographs pairing costophrenic angles, pulmonary artery wedge pressures less than 18 mm hydrorhium obtained by pulmonary artery catheterization, if this information is available. If unavailable, then a lack of clinical evidence of left atrial hypertension. If partial pressure of oxygen and relation to pressure is less than 300 mm hydrorhium or 40 kilopascals, acute lung injury is considered to be present. If this relation less than 200 mm hydrorhium or 26.7 kilopascals, acute respiratory distress syndrome is considered to be present. And about this subtopic, USMLE step test. A 48-year-old female suffers a traumatic brain injury while skiing in a remote area. Upon her arrival to the emergency room, she is severely hypoxemic and non-responsive for oxygen therapy. She started off a mechanical ventilator and 2 days later upon auscultation. You note late inspiratory crackles. Which of the following is most likely normal to this patient? Options: first, type 1 pneumocytes, second, type 2 pneumocytes, third, chest X-ray, fourth, alveolar arterial gradient, and fifth, left atrial pressure. And last syndrome for today, it is respiratory failure. Let's give definition. Respiratory failure occurs when the respiratory system fails in oxygenation or carbon dioxide elimination. It may be acute, like develops over a minute to hours, or chronic, which is develops over several weeks, months. Its clinical markers include polycythemia and cor pulmonale. Types of respiratory failure. First one, it is hypoxemic, when partial pressure of oxygen is less than 60 mm hydrorhium or 8 kilopascals with a normal or low partial pressure of carbon dioxide. Is caused by ventilation perfusion mismatch. And second one, it is hypercapnic, when it is the opposite. Partial pressure of carbon dioxide is higher, more than 50 mm hydrorhium or 6.5 kilopascals, and indicates the inadequate alveolar ventilation. Causes of respiratory failure according to types: is it hypoxic or is it hypercapnic? It can be different causes. For hypoxia or type 1 is typical chronic obstructive pulmonary disease. It can be pneumonia, it can be pulmonary edema, pulmonary fibrosis, asthma, pneumothorax, or pulmonary embolism. For type 2, more usual pulmonary hypertension, cyanotic congenital heart disease, bronchoectasis, acute respiratory distress syndrome, kyphoscoliosis, and obesity. Moreover, for type 1, additionally, COPD, we talk about it one more. I note COPD, severe asthma, drug overdose, poisoning. Moreover, it can be caused by myasthenia gravis, polyneuropathy, polymyelitis, muscle disorders, or head injury. And for type 2, it can be neck injuries, obesity, pulmonary edema, adult respiratory distress syndrome, or hypothyroidism. And more about causes. conditions that affect the nerves and muscles that control breathing. Examples include muscular dystrophy, amyotrophic lateral sclerosis, spinal cord injury, and stroke. Damage to the tissues and ribs around the lungs. Problems with the spine, such as scoliosis, a curve in the spine. Drug or alcohol overdose and overdose affect the area of the brain that controls breathing. Lung diseases and conditions such as chronic obstructive pulmonary disease, pneumonia, acute respiratory distress syndrome, pulmonary embolism, and cystic fibrosis. And acute lung injuries like inhaling harmful fumes or smoke. Signs and symptoms of respiratory failure. Most often of them include paroxysmal nocturnal dyspnea, orthopnea, pulmonary edema, cyanosis, confusion and reduced consciousness, localized pulmonary findings, tachycardia, and cardiac arrhythmias. And you see here on the slide the interesting picture of this transverse section of heart from the patient with primary idiopathic pulmonary hypertension. You see how a hypertrophy, how a thick, mostly due to right side, how a thick this muscle. Moreover, signs and symptoms can include hypoxemia, acidosis, cor pulmonale due to pulmonary hypertension, right ventricular failure, hepatomegaly, and peripheral edema. Diagnostic tests that used for respiratory failure. Checking. First of all, it is pulmonary function test. Here includes spirometry. In previous lecture, I showed what is spirometry, and checking of arterial blood gas test. It was in previous lectures too. For visualization, we usually use chest X-ray, lab test, full blood count. For example, anemia contributes to hypoxia. Polycythemia contributes to chronic hypoxemic respiratory failure. Renal and liver function test may provide clues to the etiology and identify complications associated with respiratory failure. Serum creatinine kinase and troponin I to help exclude recent myocardial infarction. Thyroid function tests to checking for hypothyroid chronic hypercapnic respiratory failure. Echocardiography to the cardiac cause of acute respiratory failure, and performing ACG for cardiovascular cause dysrhythmias resulting from severe hypoxemia or acidosis. Right heart catheterization if there are uncertainty about cardiac function. Pulmonary capillary wedge pressure. It is distinguishing cardiogenic from the non-cardiogenic edema. And scheme how we can use arterial blood gas test and interpretation of them according to level of pH, is it acidic or alkaline, and after according to this algorithm we should confirm or not confirm different types of respiratory failure. If you need it, you can screen this slide. And a scheme of approach of the patient with hypoxemia according to arterial blood gas test 2. According to partial pressure of carbon dioxide, is it present hypoventilation, is it increase or non-increase carbon dioxide, and according to it, this algorithm leads us to different forms of arterial respiratory failure. And one more and last one step, USMLE step test. A 50-year-old Caucasian male presents to the emergency department complaining shortness of breath and unintentional weight loss over the past several months. On physical exam, the patient appears quite thin and breathes through the pulsed lips. Breath sounds are decreased in all lung fields. Which of the following findings is expected on spirometry? First one, it is increased first expiratory volume in first second. Second, it is decreased relation between first expiratory volume in first second and for the total vital capacity. Third, it is decreased TLC. Fourth, normal fifth one or first expiratory volume in first second, but increased general volume capacity and normal lung values. That's all for today. It's all information that I want to give you. If you have questions and comments, if you want to discuss something or some moments looks like difficult for you for preparing to the practical classes, you should write your comments here under the YouTube video or in our Facebook page. You know it, it is a page of our department. There we're waiting for your comments, for your questions. The page is closed, that's why no one from outside can read our discussion, and we're always glad to feedback from the students, and our page is the best place for these debates, for this communication, because no one from outside is there. It's just students and teachers of our department. For today, that's all. See you on the next lecture. In 2 weeks, we will continue respiratory system. And for today, that's all. Goodbye.